Welcome, everyone. Thank you for joining us tonight for our webinar, Alternatives to Cellular and/or Tissue-Based Products in Wound Management. I'm Dr. Wendy Cole, and I will be your moderator this evening. We'd love this to be an interactive panel discussion, and we want the audience to participate as well. So in the bottom of the screen, you will see a link for a Q&A portal. So during the program, if you have any questions about anything that we're discussing, please feel free at any time to put in your questions and we'll field them at the end of the presentation tonight. So the goal for the program is to discuss a lot of advanced wound care products and our wound care algorithms with the audience. And I'm joined by Kathleen Sham. Kathleen is the president of Kathleen D. Sham and Associates, a consulting firm based in Lake Worth, Florida, that provides strategic reimbursement, consultation, and education for wound management for both manufacturers and providers. I'm also joined by Dr. Raymond Abdo. Dr. Abdo is a foot and ankle surgeon based in St. Louis, Missouri, and has been in private practice for 19 years. He is board certified by the American Board of Wound Management as a certified wound care specialist, and he is an author and also a frequently sought after speaker for podiatry and wound management as well. And then we will be joined by Dr. Stephen Heisler. He's a bit delayed, so we hope he joins us soon. He is a foot and ankle surgeon and an assistant professor in the Division of Vascular Surgery at UNC Surgery in Chapel Hill, North Carolina. And he received his Master's of Health from Lake Erie College of Osteopathic Medicine. And his practice consists of wound healing, reconstructive foot surgery, and ankle surgery, as well as clinical research. So we have a really great panel today, and we're going to kick things off with Kathleen. Kathleen, today was a very exciting day in wound care. We had the final LCD published today in regard to cellular and/or tissue-based products. So maybe you could just give us a little background on that and an update on what happened today.
Sure. Well, thank you for inviting me and welcome to all of the participants. Just want to give you a quick background on the CTPs and coverage, because this is all about coverage. And the CTPs began in the late 1990s. And when the very first four were ever launched, the MACs absolutely required to have published randomized clinical trials. And that was the only way you could get on an LCD. And every single MAC had an LCD. So once you got your published trial, then each of the manufacturers with their scientists and their physicians and their KOLs would go before the MACs and explain the new evidence that is published. And then, if indeed that evidence met the criteria for good quality evidence, then the MACs added that product to their LCDs. And in fact, there were some MACs that required 2 RCTs to gain coverage on their LCDs. Then time went by, and remember there was only 4 products then. Time went by, and there was an explosion of products, particularly when the amniotic products entered the marketplace. And at that time, then, more than 50% of our MACs retired those LCDs, but now they place the responsibility on the physician or the other qualified healthcare professional for selecting a CTP with published evidence and for determining and documenting the medical necessity for each application. So it really was then all the onus was on the physicians to absolutely be the policeman for picking products that had good evidence. Well, unfortunately, some physicians and QHPs used the CTPs without published evidence and did not really document the medical necessity for some or all of the applications that they performed. And even though most of the Macs had some type of a limitation on the number of applications that they could use, we found that many of our providers were placing 40 or 50 applications on one ulcer. That abuse caused the Macs to recognize that they had to create and bring back the LCDs and LCAs that would be based on have the evidence be based on clinically covered evidence. I can't even speak it, and would require medical necessity to be documented. Now they had a couple of unsuccessful attempts at that, but then the Macs all decided that they were going to cooperate, all the jurisdictions, and they were going to create an LCD and an LCA that provided the same coverage guidelines throughout the country. Now, the proposed LCDs and LCAs came out on April 25th. We had a comment period until June 8th. And this morning, November 14th, how fortuitous, we did not know this was going to happen. But the Max released the future effective LCDs, LCAs, and their response document to all the comments they received. Now, these coverage documents reflect many of the recommendations that were made during the comment period. So I think the Macs did a really good job of listening to what the comments were. And as Wendy said, the utilization and documentation guidelines are very explicit. The coverage is based on published evidence. And because of that, there are 13 CPT codes that cover 20 products for diabetic foot ulcer. And there are 5 CTP codes that cover 6 products that for both diabetic and venous. So the LCD is very specific. These can be covered because that's where their trial was for diabetic foot ulcers, and these few can be covered for both diabetic and venous. They have a specifically listed a maximum of 8 applications in 16 weeks to be covered. However, the applications beginning with the 5th application must be justified to show there truly is progress and has been progress, and that there's a reason to do an additional application. And that every application, when reported on the claim, has to have a KX modifier added to it. Now, these coverage guidelines will be effective February 12th. And that's really nice of the Max, because that we normally only have 45 days to get ready, but they've basically given us 90 days. So now the wound and ulcer management physicians, QHPs, and the hospital-owned outpatient provider-based departments could begin deciding what they're going to do if the CTPs that they're currently using are no longer going to be covered come February 12th. Now, some of these stakeholders may switch to one or more of the covered CTPs because there's 26 of them. Others may take this opportunity to look at other advanced ulcer management technologies that are on the market. And I'm very interested to hear what my colleagues on this panel are planning to do. So back to you, Dr. Cole.
Well, thank you. That was a great synopsis of, I think, 75 plus pages of documentation that came out today. So that was tremendous. Thank you, Kathleen. And that sets up this perfectly, because now with these changes that will be in place as early as mid-February, how will that change our practice? And I think a lot of people are looking for alternatives to CTPs in wound management. So thanks, Dr. Heisler. I see you've joined us, and
Yeah,
it looks
thank
like
you.
you came straight from the OR. So
Yeah,
we
yeah,
appreciate you getting here.
yeah.
So Dr. Abdo, Dr. Heisler, I'm going to volley it to you. How do you think this will affect your practice, and what alternative therapies have you used and will you continue to use, and how do you augment your clinical algorithm going forward?
Well, I mean, for me, we've been preparing for this for quite some time, at least at our wound care center at Mercy South Hospital. We've had the different types of like a blood product approved for usage when it comes to diabetic foot ulcerations in our wound care center. In my private practice, I've also been utilizing the non-contact ultrasound therapy in dealing with the different types of ulcerations. When it comes to how I'm going to change what I do, well, obviously we all do the standard of care, and obviously that will work sometimes. However, if it doesn't, we obviously have been utilizing different types of the camps, skin substitutes, however you want to mention it. But for us, I've never done, as Kathleen was mentioned beforehand, 40 applications when it comes to one ulceration. I mean, that's wow, that's quite a bit. But we obviously have, for us, the rule was if you don't see any changes, let's say after the third application, fourth application, we've been implementing this because we knew changes were going to be coming. We would obviously discontinue the usage and think of, okay, so there must be something else that's going on with our algorithm. And we have to figure that out.
Dr. Heisler,
Yeah.
what are your
So
thoughts?
you can hear me, good volume, everything's
Yeah,
good?
yeah, good.
Okay, perfect. So I'm kind of in an interesting position of where I am at UNC. We have basically our quaternary hospital, which is, the wound clinic is our feeder. So I've kind of always been preparing for this because we have a lot of patients with high social determinants of health. I think that we have a lot of people with poor access to care. So we were kind of forced to, try to find everything else to try to heal these patients more than we, could use the CTPs. So I think if when our practice, we would use those, when the insurance would work, and everything would go through. But I mean, we just really kind of fell back to the basics of just making sure that we had a fantastic workup. That, that patient that was referred from somewhere else, they came in and we started fresh, and whether what workup they had before. So I think we really kind of when you're forced to go back to the basics, you try to emphasize how we can make it better. And I think the focus for us was, if you can have a CTP, like this is great, we know you're going to get what 30% improvement in healing, we can heal this faster. But I think that, our biggest thing was really going back to the basics and kind of analyzing the patient and our techniques to really go ahead and help them. Because it's interesting, when we were denied a lot of times for the CTPs, the insurer would want blood flow studies, better offloading documentation and those, and that kind of like says, well, we got to pump the brakes. We're doing great, but I think we need to kind of think about things. So for us, I think we've always kind of been preparing for it. And, I think we just back to the basics and trying to find other ways of improving wound healing has been our goal.
So you make a great point, and I think that we probably have a lot of attendees that might be newer to wound care, maybe even some students. So what are your basics? What do you do when a new patient walks through the door? Maybe they've been seen by someone, maybe they haven't. What does your new patient assessment look like, your wound assessment? Because to date, I think that is the best tool in our toolbox, is a complete history and physical and a complete wound assessment to determine wound etiology and then what's your best treatment plan. So what does that workup look like for you?
Yeah. And, I'm kind of blessed with being in the division of vascular surgery. So, we're forced to say, okay, well, is this good blood flow or not good blood flow? Because I think, and I make a joke that anyone who, checks pulses with two fingers should basically probably have them removed because those fingers are not reliable at all. And so, the our PVL or our duplex Doppler is the number one. And I think would emphasize it. If I have good Dopplerable sounds, within 4 weeks, if I'm really not, seeing any improvement, then I'm okay, let's do the duplex. But if I'm seeing medical comorbidities in the HPI, and also with history of smoking, coronary artery disease, different arterial diseases throughout the body, then I'm like, okay, if it's proximal, then it's going to be distal. So that's the big thing. Then location, figuring out, okay, well, what is the etiology of the wound based on where it's located? And we're really thorough because if it's on the leg, it's not just a venous ulcer. We do a reflux study to make sure it's a venous ulcer. So depending on location and those things, our formal workup to really prove what the ulcer is. And then after that, then just, kind of looking at it and saying, okay, well, is it, is this acutely infected? What's exposed? What are the deeper structures? What's the drainage? Then kind of putting everything together. So really starting fresh, like clean slate.
Yeah, that's great. I agree 100%. And even if I see a patient that comes in and they've been seen by someone else, I don't necessarily want the records or need the records because I'm like you, I got to start fresh to make sure we work the patient up appropriately. Dr. Abdo, what,
Yeah,
if
could lead you down a
any,
path, if
oh,
you,
sorry.
I'm sorry to interrupt. I just
No,
want
no,
to
no,
get
no,
that
go,
done.
please.
I feel like if you have someone else's workup or past history, sometimes it leads you down the wrong path. And I think that's why it's all really good to really start fresh.
Yeah, I agree.
I couldn't agree with you more about the history and physical. I think that's just the most dominant place we can start off, a great springboard, and actually listening to the patient and having time to do that. I know it's difficult sometimes when you're seeing, I don't know how many patients per day, but that initial visit will tell you a lot.
Yeah, we're like an inspector, right? Trying to solve a crime. We're trying to gather all of the information so that we could say who done it. So is it the vascular? Is it the diabetic component? Like what's going on? Because
Right.
individualized care is where we really should be at with wound management. So speaking of that, Dr. Abdo, do you use any advanced technologies for your wound assessments, or how do you do a full wound assessment? We have some technologies entering into the space that I like Kathleen to comment on as well. We have fluorescence imaging, we have near infrared spectroscopy, thermography, we have all of these tools that are helping us kind of figure out what's off in our patients. Do you use any of those, or what does your wound assessment look like?
Yeah, I'm lucky enough to have the fluorescence imaging in my private practice, and I've been utilizing it for probably about 4 years, and it helps with the measurements as well and showing the progress, but also shows us photos that we can show the insurance company during any type of audits. It's a good way of tracking more accurately versus when I was a resident, we'd use the ruler and kind of eyeball it and kind of say, well, I think it's, 0.1 centimeters. I really don't know. So we use that in the wound care center, but also in my private practice as well. We have the device that measures that oxyhemoglobin measurements within the wound itself. And that's been proven to be really, I believe, quite accurate. There'd be times when, we get those studies done when it comes to ABIs or duplex, and we find out that, they're still not getting oxygen, the amount of oxygen to that wound itself. There must be something else going on. And the hospital itself seems to embrace it due to the fact that we found some, let's say, misjudgments. So those are the two different types of devices, at least for diagnostic purposes, that we've been utilizing.
And just for some context for those that are joining us, so with fluorescence imaging, the technology is such that you shine a violet light on the wound and it excites the surface bacteria. We're able to visualize bacteria at 10 to the 4th colony forming units or greater. So usually 10 to the 6th, 10 to the 7th colony forming units means that the wound is acutely infected. So we're trying to get it under that subclinical infection so we could manage it better so the patients don't become infected, and different bacteria fluoresce different colors. So that can be helpful. And then near infrared spectroscopy and some of those other technologies will tell us the percent of oxygen that's attached to the hemoglobin. So as Dr. Abdo said, even though we're getting our non-invasive vascular studies that show we have good macro circulation to the area, the microcirculation or the functional perfusion to the wound might be limited because of poor protoplasm in our patients, because they, are very sick sometimes and complex. So these new technologies are helpful. So to volley it back to Kathleen, what are we seeing in regard to coverage for these new tools, and how can clinicians best utilize them in their practices currently?
Okay. Because it's relatively new technology, we don't really have for these yet well, there's no national coverage determination, and most of the MACs don't have a local coverage determination. So that makes coverage clearly based on medical necessity. So what the physician documents is very, very important. And in some instances, the physicians really don't get paid very much for this procedure at this time, because there's not national rates currently. It's based up to every mat. So I think right now it's contractor price for the physicians. The outpatient departments do have payment for their, and it pays, and they track to an APC group. So we're in a development stage. Again, I have a lot of physicians who say, my hospital, on me, we're not really worried yet that we don't have an LCD on this, or where that maybe we get paid a small amount for it because it helps us do so many other things. But over time, as utilization grows, then I really believe we will be able to see there to be a more consistent payment for the physicians. Because there is consistent for the provider-based departments, but not the physicians yet. And I think the physicians can influence the payer by telling the payer how important this is for them to use it. And I see Dr. Heisler shaking his head, because if you tell the payer how important this is and how it could save them money, they're not going to mind to pay for this test.
Right. And Dr. Heisler, yeah, being a physician champion, to Kathleen's point, is huge, right? When we're trying to get our centers, our hospitals to adopt new technology. So what's been your experience in your practice utilizing some of these new tools, or getting your hospitals to buy in to, you know, these
Yeah,
capital?
so we were actually able to plead for several years to put it in the capital budget. So we were kind of appreciative of that. And for the time being, we've submitted some, and honestly, we need to submit more because, we're actually, one of those centers that, a MAC will look towards and say, well, is the UNC, are they doing it? So we had a conversation a while back, and I know we need to put some more claims in. It's just so hard because by the time that you put that in, the UNC will bill the patient, and you won't know for months, and then the patient gets mad. So I think we've been coming up with different types of ways of just trying to see if we can help the patient, because honestly, if the patient could be subacutely infected and not have overt signs, I mean, I love the fluorescence imaging, because then I'm able to pinpoint where the swab's going to go, or where the deep tissue culture is going to go, versus kind of doing it blindly. And I think, because that's kind of like one of the bigger technologies we use. I wish and I plead, because we do multiple clinical trials and we use different measurement devices and picture devices. And, I would love for one for our clinic, because I mean, length versus width and depth doesn't really do it, and that's the hard part is,
User
and
error too. If I were to measure it,
yeah,
then you would measure it,
oh,
then
yeah,
Dr.
Yeah.
Abdo would come in. We would probably get all three different. So it's hard to
yeah.
track that, prospectively for a trial, to your point. So yeah.
Yeah, and that's what makes it challenging for us to say, oh, we need to change treatment, or this treatment's not working, because you're really, and these are atypical, they're not circles, they're not ovals, they're not nice shapes. I mean, they're irregularly shaped, so that's what makes
You
it
mean your wounds aren't
challenging.
square and flat
Oh,
like
I wish.
all the products that we're using?
Yeah,
What?
Right.
So to that point, a lot of these wounds, they're chronic or hard to heal is the better terminology we're using now. They've been open for a long time, weeks, months, years, even though they're not overtly infected, they might have some covert signs that their contamination is getting to the point of infection. So, Dr. Abdo, I'll ask you, and then I'll have Dr. Heisler kind of chime in as well. What do you do currently to treat those wounds that we know have high bioburden and probably have biofilm, right? Anywhere from 80 to 90% of these hard to heal wounds we know are contaminated with biofilm. So what's your strategy for biofilm management to knock down the bacterial level without using systemic antibiotics, so that we know can lead to resistance and actually can be more problematic in our patients if we're not using them wisely? So what does that look like for you?
Yeah, I mean, I guess the first thing was, it's obviously difficult to diagnose biofilm, but with the naked eye, we all know that. And I do know that with treatment, it's obviously starting off with good wound bed preparation, debridement. Sometimes we'll do ultrasound, either surgical. But when it comes to the treatment, or even diagnosis, excuse me, our fluorescence wound imaging. There's a paper that was just out recently published from Diagnostics in I believe this year, 2024, and they really kind of compared the fluorescence imaging as compared to the wound blotting and then just clinical signs that you see, and it was all confirmed with an electron microscope. And mind you, nothing was 100%, but the accuracy and sensitivity of the fluorescence imaging showed to do the best. I don't know if it was 60, 80%, depending upon, I don't remember offhand. So, that kind of assists us on determining if, first of all, if we have biofilm there, right? We have to assume with the papers, like you mentioned beforehand, Dr. Cole, that 90% perhaps of these chronic wounds, which I believe the majority of what we treat, not acute wounds, are diagnosed or do have some type of biofilm. So then that leads us then to, we were gearing a little bit more towards topical antimicrobials. And, when I first started, man, I was slapping betadine like it was no tomorrow. And, I'd get what we call the betadine police coming at me saying, Dr. Abdo, this is so cytotoxic. I mean, what are you doing? And I was like, well, okay. I started reading some papers, and now we obviously try to, with any type of culture that can kind of steer us in the right direction, but we still go with the broad spectrum antimicrobial topically. And I totally agree with you when it comes to like any type of oral or systemic. In the past, I would surely jump on orals right away and say, hey, you really need to be placed on this. But now I'm looking at it differently and know that topicals are very effective. Obviously, not going past that 1 × 10 to the fourth you were mentioning beforehand. But we have utilized different types, methylene blue. We've also utilized different types of skin substitutes there, and for treatments. There's different types of the collagen with the PHMB. There's also other ones that are 3D manufactured with nano silver. So there's different products out there that we've utilized when it comes to biofilm itself.
All very good points. Dr. Heisler, how do you manage biofilm or those patients that we know are contaminated on their way to infection, but how do you cut down, that bacterial load prior to them getting to that point?
Yeah, I think that the surgeon is blessed with a better debridement than like OBGYN wound specialist versus a family medicine specialist. And I think it kind of comes back down to just a really good debridement and just making sure that you are just really removing devitalized tissue, because that's going to harbor a lot of your bacteria. If the wound isn't becoming more granular, I will try to take them to the operating room, do a more formal debridement, because I just feel like, if we're not getting that good granulation tissue, that we're not really doing the patient's justice. And on top of that is that like I can fix if I get too deep. Like I know like what to do so that I can get to deeper layers, and I know I have a really thorough debridement, so I feel more confident, because there's bacteria that's like penetrating these layers that we are kind of scraping the top of. So I think really getting into those areas and making a really clean wound is number one. We have a lot of people who have had these wounds for years, and we'll employ like a several like wound wash technique. And I mean, I know we shouldn't use Dakins and betadines and those things, but sometimes that's all the patient can afford. So we'll dilute it a little bit more. We'll be, like the Dakins will be diluted a little bit more. But we'll utilize some of the commercial products like the hypochlorous acids, and then we'll have like that be the first cleanse, the second be a saline, and those things like that. Like we'll really try to improve our cleansing regimen so we can reduce bioburden. And then for the other part of it is that we're doing X-rays pretty frequently, at least like sometimes once a month. If we're starting to see that a wound is tunneling or undermining, we're thinking, okay, X-rays are negative, the wound's been there for 6 months, maybe we need to do an advanced image. So we're really trying to kind of be on top of it before it hits the critical mass, and then obviously utilizing the fluorescence device. But for us, I think that we really then try to capture it with very simple dressings of our alginates and our significant drawing dressings, where we're really pulling fluid away, or we're adding what the wound wants and making it a little bit more moist. I think it's all dependent on the dressings, because I mean, it's sometimes, if you add these silver components and the other components, you see that it could do something and makes you feel good, but I don't really know. Like I know that the companies, they say it does, it reduces this log, but I mean, I don't really know per se if it does or doesn't. So I think it's really up to really good wound care and just having a good arsenal and knowing when to change and knowing like what subtle signs there are.
No, and I think that's a great point. And you know, being a podiatrist, training surgically, I love cold steel in my hand, right? I love a 15 blade or a curette, so I'm not afraid to go in there and debride. And I think that's a point for people that are doing wound management and those that are able to within their licensure, but like at least initially to do a really thorough debridement because these wounds are heavily contaminated, a lot of devitalized tissue. Biofilm we can't see with the naked eye, but we could see ramifications of the
Yep.
biofilm in the
Oh
wound,
yeah.
right? So you see all that slough, that devitalized tissue, that cycle of inflammation. You do a debridement, you put a bandage on a wound, and then they come back the next week and it's full of slough and devitalized tissue. Well, there's probably some biofilm going on there that's causing that inflammatory stage to be kind of, you know, the wound to be stuck in that inflammatory phase. So maybe there's something we need to do and using topical products to help when the patient is not in our clinic, right? Week after week, something at home that really fits into antimicrobial stewardship, not just putting them on an oral antibiotic, because we know biofilm is fairly senescent bacteria. They're not actively replicating. So how antibiotics work is to be incorporated in those bacteria, right? So if they're not replicating, even putting them on oral antibiotics is going to be futile, even though our patients almost expect to be put on antibiotics.
Yeah.
And there's a study I saw that 40% of antibiotics that have been utilized in the past 10 years have been inappropriate or misguided. And we're setting up all of these problems with these resistant bugs, and we're running out of options. So taking the fight to the site, using something topically to cut down on that bioburden is really key. And I want to ask Kathleen, because I know this is something you and I have spoke on before, is you know, coverage for those dressings in patients with wounds, and what should our audience know about when and how to get these products covered?
Okay, so in the practice, like if you're doing it in your office, you're doing it in the outpatient department, you're doing it in the OR, wherever, those dressings are part of the business. So you really can't get paid extra for those. The only ones you can get paid extra for is when you discharge the patient and you send them home and you want them to change their dressings at home. Then indeed, we as the professionals, we need to know what the rules are for the surgical dressing policy, because it clearly talks to us about what type of wound that we can use it on, how much exudate, etc. It even tells you what types of primary and secondary dressings we can use together. And I have to tell you, most of the time when the patient goes to get their dressings at the DME supplier, and the DME supplier says, Mrs. Jones, I can't fill this order for you. And it's not because he doesn't want to. Of course, he wants to fill the order, but he can't fill it because we ordered dressings that don't align with the clinical need for that type of dressing. And so the surgical dressing policy, which is just like the CTP coverage policy, it's the coverage policy for the dressings at home. That policy has been in place for near 40 years. And when I ask wound and ulcer management professionals, do they have a copy? Are they following it? Are they using it to write their orders and to select their dressings? They will say, what is a surgical dressing policy? And so that's really, really important for us to all listeners to know that if you want your patients to get those dressings for use at home and to have their, in particular their Medicare program pay for them, we need to get a copy of the surgical dressing LCD and its local coverage article and build that into our ordering practice.
And
You know,
debridement is a big part of that, right? I mean, making sure that we're debriding these wounds, we're monitoring and we're notating the debridement, that's a big part.
Yes, because in order to get dressings paid for at home, all right, the wound must be one of two things. The wound must either have been surgically created, in other words, post-surgical wound, or it must have been debrided in some way. Doesn't have to be debrided every visit, but it has to have documentation that it was clearly debrided. So if you, for example, if you had a skin tear, which is not a surgical wound and it wasn't debrided, it would not qualify for surgical dressing at home. So debridement is very important because that lays the groundwork for then the patient needing to getting their dressings covered at home.
Can I ask a question about that? Um,
Sure.
does a mechanical debridement count?
Yes.
Okay.
Debridement of any method, but
Okay.
it must be, the debridement must have been ordered by the physician. In other words, you ordered somebody to do it. Either you did it yourself or you ordered somebody to do it. There's got to be an order for it. All right. And then it has to be documented exactly what that procedure was. But it does count.
Yeah, that
So
reminds me as well, when you're talking about DME, ordering collagen as well, that's a nice alternative sometimes with these patients that we do. That seems to help in certain situations. So, is collagen included with that, Kathleen, when it comes to the DME?
Yes, collagen is one of the categories in the surgical dressing policy. There are very specific rules about it. And there are very specific rules about what you can use for the secondary dressing. So it's extremely important that if you are using the collagen dressings and you're running the order and you think your patients are going to get it from the DME supplier, if you haven't looked to see if it has, how much exudate does it have? What type of wound was it? And what are you going to use for the secondary dressing? For example, I see a lot of people want to take a collagen dressing and they want to put a film on top of it. That sounds logical, but in the surgical dressing policy, you're not allowed to do that. And if you think about it, it doesn't make sense to do it, right?
Sure.
Mhm.
yeah, so that's a good point. We have to notate that we are doing debridement. You have to notate the amount or quantity of exudate, and then your dressings have to be chosen based on that because it will dictate the frequency of which you can get certain dressings, right? So alginate, so a heavily exudating wound or a moderately exudating wound that you want to use an alginate, you can't put a light amount of exudate and get alginates for daily dressing changes, right? So they have to be, so it all has to jive. That's why, it all goes back to your notes and taking very good notes. And I always tell this with clinicians when I'm training or unfortunately going through documents with them because they're either, getting audited or maybe facing legal issues. It's where is your why? You have to tell your why. And so often we don't, and we have to paint that story as to, we're doing this because X, Y, Z, and it has to jive with, what our treatment plan looks like. So I think that's a great point.
Right. And it really, in the wound and ulcer management, we don't do that many actual procedures. I mean, we do a lot of procedures, but not a lot of different ones. And so learning the rules about them and reading the LCDs and building that into our medical decision making is not a hard thing. I mean, it's a playbook. It tells us exactly what we should do. All right. And we sometimes just fail to read the playbook and fail to then implement it and incorporate it into our business and into it, particularly in our medical decision making and in our documentation.
Absolutely. So, wow, time is flying and we're talking about such great things. I kind of want to steer the conversation back to some alternative advanced wound care therapies. Dr. Abdo, you had mentioned, in the beginning of the autologous blood products. So maybe can you give us some background on those products and how you're using them, what type of patients you're using them on? And then Dr. Heisler, I'm going to ask you, the same question if you're using other alternatives. Topical oxygen therapy is another alternative that has some utility. Nitrous oxide, cold plasma, they're not really in the space right now, but anything alternative that you've been using with some good success, I'd love to hear from both of you.
Sure. Yeah. Obviously, I was mentioned beforehand about the non-contact ultrasound therapy. We utilize this in my private practice, and I have to tell you, I was you get a lot of pushback when it comes to some of the camp products, but a lot of it has a very good data, and we've noticed that a lot of insurances are very accepting when it comes to the utilization of this alternative method. When it comes to the blood products themselves, began utilizing it probably, I'd say, earlier this year. And the drawing of blood, there's got to be a process. We go in there and say, "Oh yeah, let's go ahead and draw this blood right away." And 30 minutes later, you're like, "Oh boy, the vein collapsed," and you're just like, "Okay, I need to go see other patients." And
I did phlebotomy while I was in college. I worked at a hospital, and that's what I did. I was a phlebotomist, and yeah, I could speak to that. It's
Yeah,
not as easy
well,
as you think.
I'll call you next time. You come out there and help us for sure. We just, initially, so we had to set up a program in order to make this thing work. And obviously, there are certain patients as well that we thought, it just won't work. Patients, dehydration, dialysis, it just tends to be a harder stick when it comes to obtaining the blood. But going back to the blood products, we've had pretty good success with utilization of this. And, it's a whole different code. And I'm going to leave that to Kathleen. I know that. But it just seemed at first was just a whole different world for us. But as time has gone on, we it fit that nicely in our protocol. So, like I mentioned, we were preparing for something like this, and we've been working at it and studying it and what would work best for us.
Kathleen, do you want to comment on the code and the reimbursement and then we'll go to Dr. Heisler and see what else he's using?
Yes, well, this is really good news because this technology many years ago had a national non-coverage determination, and it now has a national coverage determination. So big Medicare now told all the MACs you have to cover this technology. So we won't be looking necessarily to see LCDs come out about this because there already is a national coverage determination, and it does nationally cover diabetic ulcers up to 20 weeks. And in fact, if you do, and most of them don't need 20 weeks, but if you happen to have really good progress going on and you need it a week or so at more than that, you can again add the KX modifier and be able to get additional applications of it. So we also have some great news because as we were talking about the diagnostics, we don't have a lot of what do we say, equal or similar physician payments out there right now. It's all over the board. Where when the final rule came out for the physicians for 2025, now the physicians have a national payment rate for the application of the PRP or blood-derived products. So that's great news. So if you combine the fact that you have national coverage determination, you have payment in the outpatient department, and you now have payment for the physicians, actually that's a really good thing. And I'm not a clinician, as you know, but I've seen a lot of people who've set their processes up, as Dr. Abdu was talking about, and some people are very efficient at this process, all right, because they know they're going to do it and they've got it set up and the right people do the sticks and it just moves. But that's just my observation.
Yeah, it seemed to be simpler when we were doing this in the OR as well, when we have somebody else draw it right away.
Yeah. When you have the anesthesiologist just pull it
Yeah,
up.
exactly.
Yeah,
Yeah,
that's
yeah.
beautiful. Dr. Heisler, what are you using or what advanced products do you have your eye on that you'd like to talk about in our last couple minutes before we
Yeah.
take questions?
So I mean, I utilize the autologous blood patch, and I I first asked the patient, "Hey, has anyone ever told you you're a hard stick? Are
Then
you a hard stick?" That's it. That's it. Game over. And then they're like, "Oh, I don't know." I'm like, "Okay, so let's try." But then like I have them drink like 8 to 12 ounces of water before the visit, because you ask the patient, "Did you eat today?" "No, no, I ate yesterday." "What would you have today?" "Coffee." It's like, you're already kind of setting yourself up for, challenges, but also at the same time, just, getting in a good routine. A busy clinic can be very successful with efficiency, and just trying to promote the best you can for the patient. Because when it works, I mean, it works, and it's a great product. I really like I want to start using more topical oxygen, but in North Carolina, it's actually not approved, only for the VA patients. So I really want to. So the rep kind of knocks on our door sometimes, and I'm like, can we please we try it? So I really have had a couple patients with that, and I think that's a very nice treatment. And then my CTPs are ones, I really like the the I'm trying to not say the brand name fit, but our cadaver split thickness skin graft products, I really like those.
Acellular dermal matrices.
Mhm.
Yeah,
Mhm.
yeah.
Those, because I feel like I'm always building a construct. I feel like all of these are, dealt with scaffoldings and things, and trying to build a wound into a good construct. So those are my biggest advanced treatments, other than me being the butcher in a sense of good debridements with ultrasonic debridement, which I really like, versus the alternative with a water jet, because that's pretty intense on the tissues. So I'm kind of, more towards just what I can get approved with good data, and then also just really creating a really good wound environment.
And Kathleen, what about those ultrasound or non-contact mist debriders? Where are we at with reimbursement on those products, especially in the office setting? I think they're more in tune with the office procedures.
Yeah, well, 97610, I think is the code. All right. You're talking about for the mist, like the mist products.
Mhm. Yeah, yeah.
Okay. 97610 is the code, and it definitely does have a payment rate in the outpatient department. And it definitely has a payment rate for the physician's office. Um, and there's not a specific LCD for coverage for it, but it's included. Most all MACs have a wound care or a debridement or both LCDs. And very often it's mentioned in there, and it's always in a positive way.
Excellent. Well, I think we're going to wrap up the conversation so we could take some questions. Unless Dr. Abdo, Dr. Heisler, is there anything else you wanted to let the audience know about that you are using that might fit in this subject matter?
Make sure you biopsy the wound.
Yeah, that's a really good point.
I just think that sometimes, we kind of forget about that, and we're sitting there with a chronic wound that's been there a long time. Maybe it's from another provider for a year. I think just, establishing a baseline of just making sure that there's nothing malignant or, any type of neoplasm in it. Like, I think that that's really important to mention,
Mhm.
because you don't want to be the one who misses it. That's the thing, because, a lot of these patients do jump between providers or different clinics in different areas, and that's what I'm not necessarily thinking about that per se, but I'm just trying not to like miss something that I could have done 6 months ago, realized, and then help the patient. I think when you get a biopsy that's positive for like a squamous cell or basal cell, it kind of changes the way you practice. And I think that's like really important to mention too about these wounds, is that if they're there for a long time and a lot of inflammation, I mean, that's just the precursor.
Yeah, they could switch to
Yeah.
a cancerous lesion and you might not be aware of it. So that's a huge important point. And I always get the histopathologist on the line and say, hey, I have this patient, this is what I'm looking for, and really have that communication with the
Yeah.
histopathologist. Don't just biopsy and send it off because you never know what kind of read you're going to get. You want to get them in tuned with what you're thinking and maybe what your differentials are. And I find that to be very helpful. And I often will get the slides then from the histopathologist. So it always is a cool thing to put in your presentations or in your teachings too. So
Oh yeah.
be friends with your histopathologists, folks. Aside from our vascular interventionalists, they're probably the next best important person to have on your speed dial, I think, for
Infectious disease.
and infectious disease. Absolutely. That's a like trifecta to help us. So we'll take some questions, but I want to remind the attendees that there will be a survey that will be emailed to them to complete tomorrow, and that they will get their CME certificates sent out to them within 1 week, and they'll be sent to the email that they use to register for this program. And it's important not to log off when we conclude the program tonight, because there'll be some additional important information for you. So now we're going to take the remaining few moments, and unfortunately Kathleen and I have a hard stop at 7, but the program will continue, so stay on. And Barbara, if you want to come in and see what kind of questions we've gotten so that we could hopefully answer some of those before we finish up.
Okay, great. The first question is for Kathleen. What is being done to allow PRP to be done in the home setting and the long-term care settings as an alternative to skin substitutes?
Did you say PRP?
Yes.
What is being done? Um, I assume there's not enough of that question there. But I assume they're looking at the fact that in the national coverage determination, it originally did not allow it to be done in the home setting or in a skilled nursing facility. And I just read something that came out this morning in the Medlar Matter that said that they are now going to allow that to be done there. However, I think there's a lot of not problems, but things to consider in the SNF, because if you had to do it in the SNF, then indeed the SNF would have to buy the product. And I don't think they're going to do that. Okay. But in the home setting, physician could. So I think everybody should pay attention to what's going on with the NCDs there, because it might clearly change your ability to do things in the home setting.
Thank you. Okay, the next question is, once you are down to capsule under the MPJ and can't get it to start to fill in, what do you do then? This one is a simple non-tracking 1.5 centimeter diameter. It's not large.
Who wants to take that one? What do you do when capsule is exposed, even if a small wound? What have you used in the past to help with that?
I use, well, first of all, obviously making sure that the area is clean, cultured again. It doesn't hurt to test. Like I mentioned, I believe beforehand you mentioned, you take an X-ray once a month, and it never hurts to do that. I've been utilizing a different product that's made up of from a pig liver that comes in more of a 3D type of structure, and we actually place it in there. It doesn't mean that you couldn't utilize different types of collagen, but I think the big thing is I always think of infection when I see these different types of wounds. And of course, obviously, depends upon the service, the place of service where you place these on. I know I couldn't be able to do this in the private practice where I'm at, but those are the different types of things I would use. A larger wound, obviously, everyone goes back to negative pressure. Things like that. But the PRP itself can be helpful when utilization of these different, if it comes in a different type of like gel or however different type of substance. That's just me.
Dr. Heisler, anything to add to that?
Yeah. What I'm looking for is I'm looking at offloading. And I'll do a lot of weird creative things in clinic with like dressings. Like if it's like a second MPJ or it's like a first MPJ, I'll see if like they're kind of flexible. And sometimes what I'll do is I'll have like my primary dressing, and if it's capsule, we're losing moisture left and right, you know. So what I try to do is I try to add like a little bit of moisture to the wound, because if that capsule dries out, we're in trouble, you know, because that's not coming back. So I try to change my dressings to have something that's going to retain more moisture. CDPs that kind of cover those areas and kind of stay intact for a while. I like that because it maintains a better moisture level. The other thing is that like I'll kind of fold, like I was saying, I'll fold like an ABD and put it just proximal to the wound, to kind of have the person, if they're like offloaded or just not offloaded enough, to basically hopefully hit the ABD before they hit the wound, to offload just from the dressing. I'll try to use some of the more advanced boots that are available now. Some of the wedges, even though I know people have broken hips and legs and things from some of these offloading shoes, but I think offloading is, you know, probably, if I'm gonna do anything, is number one, dressings number two, and then sometimes, you know, what I'll do is I'll try to really just try to do my best to get it healthy and clean, because that granulation tissue has to come over the capsule. So, you know, just trying to do my best.
I agree. Offloading, it's not something we didn't even talk about. We could talk about a whole other hour on offloading, but I think that's a great point. I think maybe we have time for one more question, and then the other questions that remain unanswered, we can maybe circle back to the attendees with answers on later. But Barbara, is there one good question we could wrap up this portion with?
There is.
Okay.
Okay. This physician says, I am not in clinical practice now, but when I was in the later 1970s, I was the assistant director of the now Scholl College of Podiatric Medicine Clinic. We healed a lot of intractable ulcers with usual sharp debridement, wound edge silver nitrate stimulation when indicated, customized offloading direct pads with Uniboots, boots, and if needed, total direct contact cast. Results were often as good as we see now. I am wondering if anyone presently employs these methods.
I absolutely try to use the total contact cast, kind of consider that the gold standard, obviously. And like we mentioned beforehand, at least in my opinion, you know, doing a good standard of care, you know, you have good results. Um, but when it comes to the silver nitrate, yeah, I mean, I've used that chemical cauterization of an ulceration sometimes when we have the proud flesh. Do I do it on every ulceration? No. But it does seem to work in certain situations for sure. So yeah, I mean, sometimes the old ways are the better ways when it comes to treating these ulcerations.
Yeah, I agree. I think, you know, what's interesting is that I think as a resident to like an attending and those things, I think that you're going to a lot of rep dinners. So sometimes you kind of forget about the basics. You think that you have to use these advanced products sometimes. And I think sometimes we kind of get stuck with that. And I think the basics are very, very important, because you know, when you don't have anything else, I mean, that's what you have. And I think a lot of these wounds will heal with really good wound care. We just want them to heal faster, and sometimes we get so stuck on the need to heal them faster that we're just kind of blindsided by like the basics and getting back to the basics.
Yeah, and I think
Absolutely.
that's a great point. We should all start with standard of care practices. And when we're talking about these advanced therapies, either a CTP or some of these alternatives, those really should only be leveraged when the patients are failing to heal with our standard of care practices, right? So we don't go straight to these advanced technologies or therapies. We should always start with the good basic wound care, which was all reiterated by that question. So thank you. I think that's a great place to stop this part of the presentation. And I know Kathleen and I have to go. So I want to thank everyone for joining us for the panel, but stick around because there's more content to come. So, and thanks, Dr. Abdo and Dr. Heisler, for that great
Yeah.
conversation.
Yeah, I appreciate it. It was a lot of fun.
Yeah,
Yes. Thank you.
absolutely.